Very good morning to all of you. The optic nerve is the defining pathological feature of glaucoma, and accurate clinical evaluation of the optic nerve head remains a critical part of glaucoma management. In this presentation, I would be discussing the optic disc under the following headings. The first and the foremost thing one should do when we start examining the optic disc is to determine the actual size of the optic disc. For this, one needs to carefully delineate the scleral ring. The scleral ring is a wide circular band of tissue that separates the intrapapillary region of the optic nerve head from the peripapillary region. And once the scleral ring has been defined, the disc margin is determined as the internal edge of the scleral ring. Now the disc diameters can be measured in both vertical and horizontal meridia. The direct ophthalmoscope has been the most popular instrument in the clinical examination of the optic disc. The 5-degree aperture of the Welch-Allen ophthalmoscope produces a circular spot of light having a diameter of 1.5 millimeters and an area of 1.77 millimeters square, which has an area of about 2.1 millimeters square to 2.7 millimeters square. Now, this circular spot of light may be aligned over the optic disc or adjacent to the optic disc, and then the size of the optic disc is compared to the size of the spot of light. If the optic disc is smaller than the spot of light, the disc is labeled as small, and if the optic disc is 1.5 times larger than the spot of light, the disc is labeled as large. Slit lamp biomicroscopy with handheld lenses offers tremendous advantages in evaluating the fine details of the optic disc. We commonly use high plus diopter lenses in our daily routine clinical practice. The correction factors should be multiplied by the measured aperture height value to determine the actual disc diameters. Average vertical diameter is about 1.8 millimeters and average horizontal diameter is about 1.7 millimeters. The size of the optic cup also varies with the size of the optic disc. This is an average sized optic disc having a vertical diameter of about 1.9 millimeters. This is a small sized optic disc having a vertical diameter of 1.4 millimeters. And this is a large sized optic disc having a vertical diameter of about 2.4 millimeters. So from these photographs, it can easily be appreciated that with the increase in size of the optic disc, the size of the optic cup also increases proportionally. So initially, it is very important to determine the size of the optic disc. A small optic discs have an average vertical diameter of less than 1.5 millimeters, and large optic discs have an average vertical diameter of more than 2.2 millimeters. The optic disc has a slightly vertically oval form, the vertical diameter being about 7 to 10% larger than the horizontal diameter. The shape of the optic disc is not correlated with age, gender, laterality of eye, body weight, and height. An abnormal optic disc shape is significantly correlated with increased corneal astigmatism and amblyopia, and glaucoma susceptibility is independent of the shape of the optic nerve head. As I mentioned earlier, that the larger the optic disc, the larger is the optic cup, and vice versa. In very small optic discs, cupping normally does not occur. In small optic discs with small cups or absent cups, glaucomatous abnormalities are seen in the parapapillary region. In case of myopic optic discs or in eyes with shallow cups, assessment of the location of kinking or the bending of vessels can be helpful in determination of the cup margin. In normal eyes, the shape of the optic cup is horizontally oval, the horizontal diameter being about 8% larger than the vertical diameter. It has also been found that larger the optic cup, the deeper it is, and the deeper the optic cup, the smaller is the parapapillary atrophy. Because of the vertically oval form of the optic disc and horizontally oval form of the optic cup, the cup disc ratios are significantly larger horizontally than vertically. The size of the optic cup should be assessed in relation to the size of the optic disc, and one should carefully assess whether the cup size is appropriate for the disc size. If there is a difference of cup disc ratio of more than equal to 0.2 between the two eyes in either axis, horizontal or vertical, the cups are said to be asymmetrical. But one important criterion needs to be fulfilled before labeling the cups asymmetrical, and that is the optic discs of both the eyes should be of equal size. The neuroretinal rim is one of the main targets in the clinical evaluation of the optic nerve. The neuroretinal rim size demonstrates considerably high inter-individual variability, and it is significantly correlated with optic disc area. Larger the optic disc, larger is the rim area. The neuroretinal rim area shows a characteristic configuration. It is based on the vertically oval shape of the optic disc and horizontally oval shape of the optic cup. The neuroretinal rim is usually the broadest in the inferior disc region, followed by the superior disc region, the nasal disc region, and finally the temporal disc region. This is the classical Eisen rule that we all know of, a term that was coined by Werner. So when one starts to examine the neuroretinal rim, 3 questions need to be addressed. First, whether Eisen rule is maintained or not. Second, where is the smallest NR width? And finally, whether NR loss is focal or diffuse. There is a loss of neuroretinal rim tissue with advancement in cupping, and hence the cup enlarges. The loss of neuroretinal rim tissue can affect only one region of the optic disc, either superior or inferior, or both regions of the optic disc, both superior as well as inferior. So cup enlargement can be unipolar when only one disc region is affected, as evident in this first photograph, where the cup is enlarged predominantly in the inferior direction. In the second photograph, the cup has enlarged in both directions, superiorly as well as inferiorly. So here the cup enlargement is bipolar. These photographs show advanced glaucomatous cupping with diffuse loss of neuroretinal rim tissue. As a result, the cup has enlarged in all directions. And another way to say is that the cup disc ratio has increased both horizontally as well as vertically. Neuroretinal rim tissue loss can be focal and localized, which is commonly known as notching. The first photograph shows a superior notch, and the second photograph shows an inferior temporal notch. Increasing pallor of the optic disc, and especially of the neuroretinal rim, is a typical sign of optic nerve damage. The increase in pallor of the neuroretinal rim may be more marked in eyes with non-glaucomatous optic neuropathy than in eyes with glaucoma. Here, the optic disc is grossly pale with pallor of the neuroretinal rim. At first look, one can easily label this disc to be glaucomatous, but when we carefully observe the location of kinking of the vessels, the cup is not found to be enlarged in proportion to the rim pallor. So whenever one comes across such optic discs where pallor is more than cupping, one should always think of non-glaucomatous etiology. The retinal nerve fibers, or better, the retinal nerve fiber bundles, are detectable as bright and fine striations in the inner retinal layer, fanning off the optic disc to the retinal periphery. These are categorized into the following 5 important bundles. In normal eyes, the visibility of the retinal nerve fiber layer is regionally unevenly distributed. Now, dividing the fundus into 8 regions, the nerve fiber bundles are most visible in the temporal inferior. In the temporal inferior sector, followed by the temporal superior sector, the nasal superior region, and finally the nasal inferior sector. These bundles are least visible in the superior, inferior, temporal horizontal, and nasal horizontal areas. Again, when RNFL is evaluated, 2 questions need to be addressed again. First, are there any localized RNFL defects? And second, is there an overall decrease in RNFL visibility? RNFL defects can occur in a diffuse way or in the form of localized defects such as slit-like defects or wedge-shaped defects. However, one should be aware that the RNFL defects are not pathognomonic of glaucoma. This is a typical example of a slit-shaped RNFL defect. This is an example of a wedge-shaped defect that is classically seen in glaucoma. Here, I would like to emphasize that the retinal nerve fiber layer should always be examined under red-free light. It is under the red-free light that these defects become more easily distinguishable. This is a classical example of a wedge-shaped defect. Inferotemporally, one important feature of RNFL defect is that if a large retinal vessel runs across this area, it becomes more clear and sharply detectable. The main difference between a wedge-shaped defect and a slit-shaped defect is that a wedge-shaped defect runs towards the optic disc and touches the optic disc margin. In contrast, a slit-shaped defect never runs towards the optic disc and never touches the optic disc margin. This is a typical example of a diffuse RNFL loss. The diffuse RNFL loss is more difficult to detect than a localized defect, but it is always very helpful to evaluate whether the large retinal vessels are clearly and sharply detectable. Parapapillary chororetinal atrophy has been divided into a central beta zone and a peripheral alpha zone. The peripheral alpha zone is characterized by an irregular hyperpigmentation and hypopigmentation and intermittent thinning of the chororetinal tissue layer. Beta zone is characterized by marked atrophy of the retinal pigment epithelium and choriocapillaries, resulting in good visibility of large choroidal vessels and sclera. Psychophysically, a beta zone corresponds to an absolute scotoma and an alpha zone to a relative scotoma. This is an advanced glaucoma with parapapillary atrophy. I suppose we can all appreciate a halo of parapapillary atrophy all around the optic disc. So this is the beta zone. Now let us try to focus on this crescent-shaped area of irregular pigmentation. So this is the alpha zone. Alpha zone can be found in normal eyes as well, whereas beta zone is more commonly seen in glaucomatous eyes. This is another example of parapapillary atrophy. Coming to the vascular signs can be disc hemorrhages, bionetting, bearing of circumlinear vessels, overpass vessels, and nasalization of vessels. Splinter-shaped hemorrhages or flame-shaped hemorrhages, also called as branch hemorrhages at the border of the optic disc, are a hallmark of glaucomatous optic nerve atrophy. They are seen in about 4 to 7% of eyes with glaucoma, and in early glaucoma, they are usually located in the inferotemporal or superiotemporal disc regions. They are associated with localized RNFL defects, inara notches, and circumscribed perimetrical loss, and they indicate progression. These hemorrhages are visible for about 8 days to 12 weeks after the initial bleeding. Detection of these hemorrhages requires careful examination because they can occur anywhere on the disc and also vary in size. What is bionetting of vessels? Now, with advancement of cupping, the vessels emerge from the floor of the cup, then ascend up the steep wall of the cup under the overhanging wall of the cup, at which time they are not visible to the observer, and then emerge again at the disc margin, making a sharp bend, and that resembles the bayonet of a rifle. Circumlinear vessels are small branches arising from the retinal vessels seen in about 50% of normal eyes. With the enlargement of cup, the circumlinear vessel remains in its position and the cup margin recedes further. So, and as a result, an area of pallor appears between the cup margin and these vessels. As the neuroretinal rim narrows, the loss of nerve tissue leaves this vessel isolated or bared. So acquired bearing of circumlinear vessels is an early sign of rim thinning and thus diagnostic of glaucoma. Normally, the vessels run over the surface of the optic disc and the neuroretinal rim and then come out. A loss of neuroretinal rim takes away their posterior support and they appear to hang over the optic disc and bridging the optic cup. So this is also known as overpass cupping. Normally, the retinal vessels enter the eye along the nasal border of the optic disc and their branches run along the margins of the disc and cup and then emerge somewhat temporally. With enlargement of the optic cup, the major vessels may show a further nasal shift. To summarize, the vascular signs can be hemorrhages at disc margin, bionetting of vessels, bearing of circumlinear vessels, and overpass cupping. These 4 vascular signs are specific for glaucoma. Diffuse and focal narrowing of the retinal vessels have been described for both glaucomatous as well as non-glaucomatous optic neuropathies. The generalized and localized narrowing of retinal vessels is typical of optic nerve damage, but not characteristic of glaucoma. Exposure of the laminar tissue occurs secondary to loss of neural tissue. The pores of the lamina cribrosa can also be seen in normal eyes as well. In normal eyes, these pores are usually round in shape, but in glaucoma, as cupping increases, these pores become more slit-shaped. So appearance of these slit-shaped pores on the lamina cribrosa is known as Laminar Dot Sign, and this sign is not specific for glaucoma. Optic nerve head changes in glaucoma can be classified in many ways. Changes can be structural, contour, and color changes. Changes can also be quantitative or qualitative. Changes can also be categorized into intrapapillary and papillary regions. So finally, when one starts examining the optic disc, one should remember the 5 R's or the 5 rules. If you remember these 5 R's, you're not going to miss anything. So what are these 5 R's? First, observe the scleral ring to identify the limits of the optic disc and its size. Second, identify the size of the neuroretinal rim. Third, examine the retinal nerve fiber layer. Fourth, examine the region of the parapapillary atrophy. And finally, look for retinal and optic disc hemorrhages. To conclude, I would like to say that careful assessment of the optic nerve head is probably still the best way of diagnosing early glaucoma. Thank you for your patient